Good morning, everyone, and welcome to Signals and Symptoms podcast with my besties, Edward Marks and Harvey Castro. He's going to be joining in a second. He's having some internet connectivity issues. I am so excited to welcome Dr. Kim. He is in our backyard. He is at Baylor Squat and White, and he actually does lead physician informatics team in the Plano Hospital. He has published some really amazing LinkedIn posts, and I just wanted a real person who's actually implementing AI to hear from that exact physician who is doing it and leading it. This change in charge, which Edward Marks continue to speak about, is going to be extremely important. As usual, I'm going to toot my own horn with some of the major significant updates. It's unfortunately a lot of them, so I'm going to flash through them. Towards global standardization of software as medical device, it's extremely important for companies like us. We already have one FDA approved class 2A clinical decision support, and now we were thinking of, we have Saudi FDA in process, and we're thinking about potentially, going to, let's say, Europe, and they have their own standards. And I think that is something that is important for us, that we should have global standards actually culminated into one, and therefore we have one application that can go and use in different places. So I'm extremely excited about something like this. Not this is just a pipe dream. They have actually done it, a complete research on it, that how GDMP can go into unified quality standards, validation protocols, etc. So must read, very important. MedArena comparing LLMs for medicine in the wild. This is again Edward Castro. Sorry, our Edward Edward Marks always says that we are in the wild, wild west of the medicine, and it is so true. And as a matter of fact, if you just read the introduction, this is so cool. FDA guidance suggests LMs are not considered software as medical device and may be regulated with lighter touch. This is opening up. Again, people like Dr. Kim is going to be so important, like how he can speak about it if he wants to, that how he's evaluating these solutions, what is his process, etc. But this actually has a website, medarena.ai. It's very good. It compares, I suppose, Gemini to LLM, etc. And you can upload your own. I don't think so. You can upload your own model, which we do. But at the end of the day, they are actually comparing all of these and then gives you results. Again, you have to do it for cardiology, ophthalmology, orthopedics. Again, fascinating way to look through this. This is essentially part and parcel of Agora. Agora is a platform that does LLM comparisons. If you want to host it yourself, we use that internally. Understanding clinician information need for AI-driven clinical decision support. And this is such a good value written, that how actually physicians want to do it. 8 clinicians and 8 AI experts want together how to do the model card, how to do the model facts, etc. Important, fascinating read that everyone should read through this. Teaching multimodal M to comprehend 12-lead EKG. We're going to talk about this. Now, EKG essentially is a data format. When you go directly from the EKG machine, you get what we call the signals, like the sine waves, and that's one way to do it and predict it. That's some EKG machines do it on within themselves. But what if your EKG was essentially an image? How do you actually go ahead and interpret that? So this is an important problem, because sometimes EKG machines are not actually integrated, and they have the actual paper with the code. So again, I think it's very important read for those who are working on it. This is can be an easy ad, by the way. Just a reminder, this will be needing an FDA approval if you are looking into this. The role of agentic artificial intelligence in healthcare. Harvey, this is something I thought you had written it. But if not, we need to co-write this for us, because this is again in press. But one of the things that, if you go through the very bottom, they were able to basically look through the whole system, like where are this it is, and then was able to give like where are the different places where agentic AI can make a difference. Very interesting paper. I'm going to send you directly so that you can review it. I know you're traveling. Redesigning leadership for clinical AI deployment. This is Ed's territory. By the way, just a reminder, my bestie Ed was an ex-CIO of Cleveland Clinic, is on multiple hospital boards, and now his whole thing is that, and it's very interesting, that the leadership needs to change, change to the younger self to improve not only development but deployment of AI. So again, a fascinating read. How do you actually redesign it from the ground up, the leadership itself? AI literacy mediates AI assisted diagnosis, participation, and critical thinking among medical students under supervision. Again, Ed, which is not a physician, and a very important part of this discussion, is always been talking about that education comes first. They were able to compare interesting ideas about AI assisted diagnosis, participation, and critical thinking, and comparing it. And as we have discussed before, that is going to AI make us physicians dumber? I told you yes. As a matter of fact, we have been using stroke based imaging CT analysis, and I've seen my stroke physicians becoming not as good as reading at CTAs because they're using AI as a crutch. Regulating complexity in AI enabled omics. This is again, I love to read, so I'm just gonna say it's a very good read. But other than that, nothing too exciting new about it. Quark MedBranch, a real world scenario benchmarking for evaluating LedgeWorks. This is, we have talked about benchmarks before. I love this benchmark very much. As a matter of fact, it actually has all four of them. Let me find that particular where it is. That it's gonna do not talk about like AI scribes, CDSS, even guidelines, etc., etc. So I love this benchmark. This is a a very good benchmark. Anyone who's using and evaluating these are important. This is fascinating. Actually, I did all of this freaking insane work, and now they're going to publish it. So they are basically this is from Stanford. They're using 3D medical image representation, and the image comes in, and then it auto mode. Do you see that auto mode segments everything out and then creates a automated mask? And what it does is that literally it creates for me automatically. For example, this is what I'm exactly deploying right now for vessel imaging, is that I can automatically do auto labeling. So my first labeling for FDA is done. I can run experiments, decide from a business case scenario if I'm going to build that model or not. And then, of course, I go to radiology to do labeling and everything. So we have officially moved to what I use the term internally as, they use self-supervision. It's basically auto labeling to be done on any radiology. I'm going to go ahead and move this over here. Sixth intervention responsible for ethical implementation of medical AI agents. I specifically added this because we're going to remind people that Dr. Harvey Castro is working on a governance way of helping any company, clinic, or anyone to actually be able to generate basically a governance pattern where they can have responsibility, ethical, and of course, a part of it is going to be where we might come in is how to monitor them. So this is where the important read if you're looking at it. Oh, this was such a good one. Shattering the shortcut, the topology regulates multi-hop reasoning in LLMs. Now, multi-hop reasoning is a specific problem in which when you say that, for example, that a patient has this EKG, then they're going to have a second question, and then the third question, the multi-hop structure is extremely hard because it loses the context. What they were able to develop was essentially, a proper way of evaluating them. They have a whole website around it as well. So you can see the data set, you can see the results, and then eventually, apparently, they're going to show all of the stuff in their GitHub as well. So very well organized, very good research work that was done from these. We talked about this, not only that the large language models can do Alzheimer's decision and phenotypes. I talked if you do a voice recording, which we are working on personally to see what the latency is from January to March to July, and then you can actually say that the latency of the speech is getting worse, and therefore you can actually create that how fast dementia is moving, which is also important for phenotypical representation. Again, there would be separate app for the families and everyone who would just record once a day or twice a day and say, okay, are we moving towards it? Important for Parkinson's diagnosis as well. Advancing conflict diagnosis, again, this is what we are looking at. I'm going to talk, I just showed this because I want to show you the next one, is this. And this was announced at HIMSS. TEFCA and health tech ecosystem work together to drive data exchange. This was actually released last year by CMS 2025, that how they're going to basically create what we call API-focused data exchange framework. And they are making good strides around it. They have actually now added some companies. This was, as I said, July 2025. President Trump actually announced it, and we saw that this is coming in the future. So these are major updates. I'm not going to go through this today, but just an FYI, I have been using Notebook LLM more and more. Basically, for example, we're going to talk about physician burnout. It just honestly is getting insanely better. I don't know, Harvey, have you been using it? But coming
Oh yeah.
back to Dr. Kim, sir, I'm again very grateful that you joined. I would like you to properly reintroduce yourself, and then the floor is yours essentially. What do you want to discuss? The only boundaries are healthcare and AI.
Oh wow. So hi, my name is Andrew Kim. I'm the director of physician informatics for the heart hospitals in Baylor Scott and White. So I work in with everything and anything with the EHR as well as any sort of, like you said, healthcare and AI. Right now, AI is obviously one of the biggest thing in healthcare. 5, 10 years ago, we heard nothing about AI. We heard everything about blockchain. Do you remember that? Every vendor was blockchain, and none of them could explain what blockchain did. But now, every single vendor you go to any conference, and you just see AI everywhere. I think it has a lot of opportunities, but I do think right now the market is extremely crowded because every single vendor is working on their AI solution and not really working on the main thing that, you know, how does it service the patients? How does it service the clinicians? Right. But I think there are some gems in there. One of the things you were talking about, the LLM, I think um, our main goal I work with one of our chief wellness officers, and he has a main focus goal, which is actually addressing physician burnout. And in fact, we actually have a physician well-being symposium coming up next month where we discuss what tools we're using to mitigate physician burnout. So one of the things we're looking at is our current ambient listening product that we're utilizing in the clinics and in the inpatient setting as well. And we are currently actually pulling data to see, is it truly mitigating physician burnout? Is it truly reducing their workload? And also, what are the outcomes? Are they writing shorter notes or longer notes? Are we addressing any pajama time or work outside of work hours and things like that?
So grateful that you are doing such amazing work and actually finding real world evidence, because there have been studies for ambient listening which are different. And then honestly, I had to redesign my UI for my ambient listening portion to actually ensure that the documentation review burden is not equivalent to documentation burden. And therefore, how do you control for accuracies? How does it mark out? And then blah blah blah. But anyways, so thank you, Dr. Kim, for coming online. I'm gonna first let Ed start today because you used the word wellness, and he is a very big wellness proponent as well. So, Ed, why don't you start with your first question?
Yeah. Hey, Dr. Kim, thank you so much for those insights. It's always great, as Junaid said, to have an actual practitioner as opposed to just a strictly academic, if you will, talk about this topic and actually doing things. So yeah, I am super curious. I know you're early, as you discussed in the analysis, but what's your sense, and maybe for yourself and your closest colleagues, like, is AI truly helping yet, or where do you think we are on the maturity curve in terms of enabling a better lifestyle for clinicians?
I think it depends on who you ask. One of the challenges that we run into as in informatics is that every physician has their own workflow, right? And you try to kind of set this workflow. A lot of vendors will create a workflow for the physicians and hope the physicians will adopt to it. And and as anybody knows, if you try to get a physician who's been practicing the exact same way in the past 20,
Yeah.
30 years, they're not going to adopt another workflow. Their workflow works the way it does because they've been doing it for so long. Their notes look exactly the same because they've been doing it exactly the same way for years. And if you try to give them some sort of a workflow where, oh, you need to change your template to match our model, it's just not going to work.
Yeah.
So that's where I come in, and I try to kind of marry the two together and make sure that can we get the vendor to modify their model, and can we get the physician maybe not to modify their model, but try to tweak the workflow just ever so slightly so that everything works a little bit better. Anecdotally, I will say that our physicians are saying that their notes are done, before they go home, and they love it. Data-wise, I'm not really sure we're seeing that just yet.
Yeah.
But we are at the very beginning of it, so we really can't say much about how that's turning out. In terms of AI tools and adoption, I think we're at the very beginning of it all. You know, right now we have this massive, boom of all the AI companies out there, and I think we're slowly kind of shedding and trying to figure out which ones are actually diamonds. And I think in the next year or two, we'll really discover that the few companies that are remaining will be the ones that stick around.
And yeah, I think that's good insight. I kind of hear the same thing when I travel around the country talking with different colleges. It depends who answers that question first, interestingly, right? If you're in a conference room and you say, hey, how's X or Y or Z working? Whatever the first answer is, everyone agrees. So they could say, oh, this AI is working great. It's really helping with, clinician burnout. And everyone's like agreeing. But if the first answer is it's not helping, then everyone agrees with that. It's very interesting. But what would your recommendation be for, this is largely, we're very clinically oriented here. However, I know we also have listeners and watchers who are more on the tech side. What would be your advice working with IT people, or chief digital officers, chief information officers, the people that you might interact with, and how to best work with clinicians to partner to make sure you get the best solution and not this fragmentation that you were talking about, these kind of best of breed silos?
Yeah, I mean, I think that's the main goal, right? You have the tech people that are developers, analysts, and code writers that have never really stepped foot inside a hospital. So they might have a brilliant idea, but they have no idea how it may fit to a clinician's workflow. And then you have clinicians who clearly have a problem and they want a solution, but you really can't marry the two. I think the main thing is, it's just like any sort of sales, right? Find out what the problem is first. We'll learn their workflow. Yeah. And like I said, every physician has their own different workflow. You could talk to one cardiologist and another cardiologist, and you'll find that they have completely different workflows, completely different ways that they place orders, see patients, write notes. And you can't, although the industry really has to try to make everything fit, size fit one, but you have to try to modify it so that it may service 80% of the population. And if that's the case, I think you got a winner. But I think a lot of the companies, their main number one problem is they try to find a solution to a problem that may not exist or that may not address the actual problem itself.
So two things that you relatively said. Number one is personalization of AI for the physician workflow. That is extremely important. And then number two is, as you suggested, find the right problem to solve. That is very, very important. And then more importantly, if you solve a problem, how do you actually push it into workflow? Because as people have suggested, that even if you design a solution, if it doesn't work through, that is a problem. I'm going to hold on to my questions and I'll let Harvey know. And then we'll go into some of my questions.
Yeah, Dr. Kim, thanks for coming. I'm really big on culture. And back in the year 22, I wrote a book called ChatGPT Healthcare. I'm writing the second edition right now. And the reason I mention it is I think a lot of it is we don't know what we don't know. We know medicine, right? But do we all know AI? Do we understand it? And if we can understand it, then I feel like the culture can change, and that's why we're doing this. And I'm curious from your institute, if you're able to share, what kind of things are you doing to change the AI healthcare culture? Is there workshops? Are they going over stuff? What have you noticed?
Yeah, I mean, obviously, ever since the boom of AI, we've had a lot of clinicians go to conferences and talk to a lot of people about AI and what it can do for them. And they seem to come back to me and say, what can you look at this? What about this company? And I think some of them, will really help their workflow and it help their clinics, but it doesn't really address the institution as an overall. We've set up AI governances within our institution where a lot of our leaders sit, as well as ethics committees, legal compliance, and clinicians as well, and tech people. So you kind of want everybody to pitch in and make sure that this is beneficial, not only to our clinicians, but obviously patients, number one, and our clinicians as well.
Awesome.
Love it, Edward. I agree with you. This is important that we need to go from pajama time to lingerie time. So here's the thing, Dr. Kim. When I was a resident, I was in SLU. I was the first year of paper charts. And before I go into that, what I was thinking is that within that time, there were people who were actually on the older side and they just retired early. So who's going to fricking deal with this crap anymore? I have enough money, go from there. And this comes to one thing is culture. And I mean, you know, you're looking at young horses here, me, Harvey, and Ed. But what I'm saying is that have you seen a curve in terms of adoption and clinician sort of readiness to adopt? Again, look, there's a new tool. There's a new tool. You cannot use the same hammer to drill a Phillips screw. So the question for me is that one thing is culture, where you can actually say, okay, you know what, this is the new insight, advocate, advertise, etc. But at some point in time, what do you think is happening in a year, 2 year, or 5 years from now?
I do think that, I mean, you kind of nail it on the head there. So you were at SLU, so you were at paper, and I actually was part of the Wash U Epic Go Live team when they went live. And I distinctly remember a neurologist there that was kind of on the older side. And obviously he had difficulty, going onto an EMR, much less a computer, right? He told me, he said, Dr. Kim, I don't use a computer at home. I don't have a computer. I don't know how to use the mouse. And I knew that it was going to be challenging. And I think in the end, he did retire after spending a few months trying to adapt a new system. I don't think I do think there is an age component, but I'm not so sure it's an age component, more so that it's the willingness to learn. We have older clinicians that are completely into the new tech. They want to learn more about AI. They want to, learn more about how this can help them and benefit their patients. So I think it's just like with anything. But one of the things that you just said, you can't use a hammer to nail in a Phillips screwdriver. I mean, yes, you're right. You can't hammer it in, but you can use the other end to twist it in. And that's kind of the way I'm looking at it, is that you give them a new tool and maybe we can tweak it just enough so that the clinician can utilize it to benefit them. It might be a little bit more challenging. It'll take work on both sides, clinician and the tool itself, but I think we can get there.
Yeah, one of the
so
issues
right,
with that.
Sorry.
All I was going to say, I agree with that. One of the issues is when physicians are doing things differently, they may start using their own tools that may not be HIPAA compliant. They might be doing some side hacks. They're like, oh, wait, I can do this in 2 seconds on my AI. I don't want to go through the hospital system. So that's really the core issue when it comes to what's going on in the hospital. And we need to work on the workflows, because if it's not going to be smoothly into it, it's going to be chaos.
Actually, that's Dr. Kim is a very, very standard question. Hey, get this tool, or I'm going to still use it. Has that happened to you?
Oh, not so blatantly, but I don't think any clinician has utilized a tool outside of our institution rules. However, they will ask, hey, I saw my colleague at this other hospital using this tool. Can we get it? And I'll say, well, let's evaluate it and let's take it through the proper channels. And I'll say, can we just get it for myself? I said, no, we can't do that. We absolutely cannot do that.
So just to let you know, from a user experience perspective, for example, I had to go through a whole personalization. How do you round subjective, pertinent history, objective, assessment, plan? You can literally deep dive into exactly the way you want to write a note. And this took me a while to fix it, because every physician that came to me had a similar problem. Working on templates, we developed, for our Radio View AI, we developed like 4,000 templates. But still, the best way is that people are coming in and basically adding their own template, believe it or not. It is the physician workflow is so specific. They want this to be that dot to be there. And therefore, we have to build our AI around it. to basically use their own templates and therefore move towards this process in a way that they can add their own snippets, they can add their own hanging protocols, which are all AI based. But the idea was that they could have, this maturity of situation where they can actually, add, and of course we're adding custom node builders specifically for you, Kim, to actually be able to monitor where this data is going, because AI extraction is also very important. What was the last one? Well, on a stroke, does not need to go through a whole process through Epic to extract those details. You can just get them right then and there. And that's where my second question is. We always talk about patients, which is important, without a doubt. I mean, not, and then physicians, of course. But then there is the care systems aspect of it, which I do a lot because I was the director of neuro ICU, director of stroke, get with the guidelines, and I'm looking at it. There's a couple, hey, why this patient was given TPA, there was a bleed. Now I have to evaluate the patient and I have to say, okay, which physician gave it? Out of the 26 hospitals, how many TNKs he has given? I have no freaking idea. And I'm looking at it and it's like, okay, that's fine. Why don't you give me one sheet of the actual data? Nobody has it. Yeah, here's the chart. Are you kidding me? For 200 pages, I have to review them and then figure out if the patient was right. If this is something going to be requiring, my direct supervision for re-education or whatever that case may be. What I'm saying is that the third one, which is the informatics part, where you actually shine, give me your vision of current capabilities that you think, and then future, how important that will be, including RCM, like whole hospital's revenue cycle can change. And then what Edward always asks is the AI wars between the hospitals and the insurance companies. How are that going to adjust as you see forward the back office in a clinic or all of that?
Yeah, I'll address your first point. It's funny you mentioned that. We were actually evaluating a vendor who what they showed was they basically used LLM, read the whole chart, used OCR, and read all the PDFs and summarized the entire hospital stay into one neat little page.
Okay.
It should theoretically cut down on chart review, theoretically. But like you said, you need to look at who gave what at a certain time period within the certain time admission stay. And I think that's a little bit more nuanced when you're looking at very specific details. One of the things that I think we find challenging is that in the future, and I'm afraid to say this, but maybe you can actually just ask some sort of LLM or GPT into your EMR and say, who did this when? And it'll spit back an answer. And I think we're kind of halfway there.
Not too much future, Dr. Kim. I'm going to show you in 3 months. And the reason is that I actually had the courage to work with a personal injury, which I didn't realize that how much law is involved in a patient chart. And then the lawyers need to review this patient chart exactly like you were asking, which everyone's going to hate me for it. But anyways, what I'm saying is that they actually had it because they don't understand the clinical terms. They wanted a language model that can explain the language terms for them, find the exact date and the document where they're looking for and everything. So we built this. We're going to present it in 2 months, and I'm going to write a paper on it. But you're right, absolutely. It's not that distinct future, especially how, just a reminder, Google actually released Embedding 2. Embedding 2 greatly increases the overall RAG efficiency and proficiency. We still don't do it. We use a completely different system because we don't want to use RAG accuracy. We actually go through a very different process, which is proprietary. But what I'm saying is that in general, the overall accuracy will increase, in my opinion, given every single day there's something new coming. Harvey, what are your thoughts on it? As far as, you talk to ministries, you talk to, countries, not just, low-level people like me. I'm grateful that you always put me in high regard. But what I'm saying is that, have you seen that the back office, the back end, which is massive, by the way. If you look at it, there's 9 administrators for one physician. So I'm going to talk to Ed afterwards. So you talk to me about like what you see the vision. And Ed, do you think all these administrators need to find new jobs?
Man, that's a good one. Okay, so big picture, I want to go back a little bit to what Kim was talking about because I think it's important for people out there because we have the bell curve of people listening. So I want you to understand the practice of medicine is the art of medicine. And so there's a lot of variability among us, even though there's guidelines, and even with those guidelines, there's shifting and where AI helps. And so my point is this: you're creating a model that it's fluid, that's also time stamped. You're creating algorithms that say, here's the guidelines, but then not everybody's keeping up with the guidelines because it changes. And then the science is changing faster than we can actually make those guidelines. And then you have the variability among the doctors that practice of medicine. And then you're going to someone like Janae and saying, here, take it, and this is what I want. But what I want is 5 different versions of what everybody else wants. And then to make it more complicated, let's talk about the C-suite. Then you got the C-suite of a lot of non-physicians telling physicians, this is how medicine should look like. And then the physicians are like, wait, that doesn't make sense to me. And so what will continue to change and morph is I'm going to encourage our healthcare professionals to be in the C-suite, to understand. I was lucky in that I had about 400 employees and a team of physicians and nurses that I created a healthcare system. So from a C-suite point of view, I see it, and from the AI. And so in summary, what I'm trying to say is what I'm seeing right now is this tension. And going back to summarizing what Andrew said on the age gap, it's not necessarily like an age difference. I agree with you. I think it has to do more with early adopters and late adopters. And as a result, we're starting to see different ways of doing things. And so going to now, to Ed's part, I do think what I start seeing is there's going to be a shift, and that shift will start looking like a better consolidation of understanding that whole AI and healthcare platform. And as a result, that'll give them a competitive advantage against other systems. And I think that will be the predominant way that's going to move forward in the future. Sorry, that was a lot.
Ed, who are you firing?
Yeah, well, it's interesting. I put in the chat. I was just typing into the chat. I'm in Korea right now, and they have a big annual medical conference which starts tomorrow morning, and the theme is, of course, AI, but the healthcare world is flat. How new technologies impact global health. Kind of taking a global view out of Korea. It's pretty progressive, a lot of innovation. But anyways, yeah, there's the thing. It's a big deal here where it's, the Minister of Health is involved and opens up, and it's a kind of a government public-private partnership. So there's a lot of clearly there's tremendous opportunity, right? You see the headlines all the time. More and more health systems are letting people go. There's a lot of risk happening because the cost structure is too heavy. And how can we leverage AI? And on one hand, I can give you examples. I won't give you specific examples because out of confidentiality, but some places they've stopped the amount of reductions they're doing that are based on AI because of unions, and so you have that sort of going on. But that's the opportunity, how much you can actually reduce. So I think a lot of back office functions, I think I've described before, where I was amazed myself when I was visiting. Again, I have to keep it kind of general because it really does apply to all health systems, but I walked into like a warehouse, like a Sam's Club sized warehouse, and it was like cube after cube after cube of all these individuals doing, obviously they were using computers, but still a lot of manual work using a computer. And of course you should, this is a whole nother topic, but I have to say you should never drive to use a computer. If you have to drive somewhere to use a computer, it's not good business. But they'd have these factories of revenue cycle people as well as IT people. And I think obviously you can use a lot of AI today to displace a lot of that. And again, nothing against great people, wonderful people. We obviously mean no harm. It's just an alert that we should re-educate ourselves, refocus. I think someone already mentioned that earlier. It's like, hey, you got to be continuously curious and reinvent yourself and find new ways and become part of the AI revolution, if you will, as opposed to being, dramatically impacted by it and losing a job. You can actually, leverage all the things that we're talking about here and other things to really create a new opportunity for yourself. But yeah, obviously, again, revenue cycle is a big area where a lot of automation could take place and significant reductions. IT is another place that you could leverage a lot of AI. I think all of our systems, we're pretty bloated, right? Over time, we just kept adding, and not really making those hard decisions that we can make. So hopefully, Junaid, that answers your question. Oh yeah. So I see
Dr. Kim, this is my prediction that in the next 5 years, we're going to decrease the ratio from 10 to 5 thoughts, given that now you're on the first, as you clearly say, we're very early in this whole phase. People don't understand that. People think that AI is in here already. People think OpenClaw is going to take over. Oh my God, they don't understand the first thing about, especially healthcare, because you have to change, not the first, you have to change the physician behavior. That takes a year or two, 18 months. Then you have to change, the what do you call leadership, then physician, and then it's going to trickle down to back office and information that you are at. So walk us through this. What is your sense of things moving forward, that as, and I'm not going to get you in trouble, so don't speak about unions, just so go ahead.
No, I mean, I think I don't know if the ratio will decrease. I think maybe, I think the shift will be essentially their roles and what they do, right? Like you said, the automation of RCM, that's kind of a big topic right now, pre-authorization, denial claims, and all those. But what if essentially those job roles shifted from working on pre-auth and denials and fighting the insurance companies to maybe utilization and making sure that each single procedure or admission actually has the necessary documents and has the necessary filings before it even gets to that phase. Not to mention, I had this chat with a smaller AI company that basically told us that they would fight the insurance companies using their AI. And my number one question is, so your AI is going to fight their AI, and we're going to burn up 1 million trees, and we're going to see a denial, and then what? And they said, we don't see denials. I said, there's no way. This is it's AI versus AI. Somebody's going to win and somebody's going to lose.
And through my research, when I was like radiology reports goes through, interestingly, there's an 11.9% denial rate last year. Of them, 75% of them was due to documentation. When I improved the documentation significantly because of my AI, the denial rate only decreased by 20%. And I said, what the hell is going on? Apparently, they have a gate over there. They will deny, period. It doesn't matter like how good your documentation are. You just have to go through the claims process, period. Anyways, the claims, but the value that it brings is that when you go through the claims process, you don't have to go to talk to the physician, hey, improve this documentation, and then go from there. So there's definitely massive value. And then your whole denial curve becomes much faster and then submitted through AI. But no, I didn't realize it, but interestingly, I didn't know that. Ed, did you know that? Or Harvey, when I actually talked to the insurance companies, like, how do you deny it? It is already in the report that the question you ask, apparently they have a gate that they have to deny 10% of the claims just to, I don't know, keep the shops running for those factories of human beings that are coming to driving 10 miles and 20 miles to come and review this. But anyways, that was very interesting knowledge for me, but when I was building it. So yes, Dr. Kim, by the way, if anyone is suggesting it's not even possible, because believe it or not, they have a gate. Utilization review is very interesting. Since everyone has a bell curve in this, can you remind Dr. Kim what utilization review means? And Harvey is going to work on governance, but let's say we have another young startup founder who's going to build AI for utilization review. What do you think would look like?
Oh man, I mean, it's like Harvey said, it's a moving target because those rules change all the time. We have incredible utilization nurses that look at upcoming cases in the OR cath lab, and what they do is they make sure that all the procedures that are upcoming has all the necessary documentation, orders, accommodation code, admission status, making sure that the H&P is up to date and within a certain time frame. And like I said, the diagnosis is also attached properly. And those rules kind of change from time to time. I mean, there are some core rules that don't change, but admission status changes from CMS and Medicaid. So I think they really make sure that the cases don't get canceled or delayed, and they have to ensure that all these things are there. We did try a very cursory approach of building not an AI tool, but something where a human can look at a report to make sure that all the cases have what it needs. But even then, it still requires small nuances of knowledge that, oh, this procedure needs this, whereas that procedure does not need that because of the payer, so on and so forth.
So Harvey, by the way, me and my besties are finally going to meet in Dallas this Monday. So we're going to post some pictures. Because believe it or
Finally.
not, Dr. King, it was insane that everyone's traveling so much that we are doing this every week, every Wednesday morning on the clock live, but we were never able to meet physically in Dallas, except for once that I was invited at Ed's, book launch event. So I was at South Lake's place. But anyways, so Dr. Kim, this is one thing that I ask everyone, that if you had one wish and you would have a magic wand and you will only fix one problem, what would that be?
Oh man, that is a tough one. Gosh, I think the one wish would be is that, and I'm not even sure if it's possible. That's why I have a magic wand, right?
Yeah.
I think one of the biggest challenges that we run into with at least EHRs, and that's why we have all these different tools now, is that the EHRs have gotten so complicated, right? And they're so costly, they're so complicated, and you need to hire an entire team in order to run and fix and troubleshoot and train. If I had one wish, is to make the simplest EHR that with the cleanest UI that even that requires no training and yet does all the things that a complicated EHR does.
Just to give you some history background, there are 1,300 EHRs currently in the United States. 500 of them are actively used. Mind you, 500 EHRs being actively used. I think you hit the nail. There are very few. As a matter of fact, when I was building this AI scribe and radiology and everything, looking at the user experience constantly, because how would I use it? How would I use it in an ICU setting, but also in an epilepsy clinic setting? How would that work? It is a hard problem to solve, Dr. Kim. It's not easy, but we'll see some strides going forward. I agree 100%. EHR is one big issue, and the second, which is for me, has always been the data aggregation. Harvey, your floor.
Yeah, I'm gonna take on that question. For my magic wand would be I know you guys are gonna cringe when I say the word. It'd be like the Her movie where I could just speak into the phone and be like, "Look, what's going on with my health?" And then the phone's like, "Dude, you haven't slept, you haven't been doing XYZ, you didn't work out this week, and I predict you're gonna have a heart attack if you keep this up in 2.7 years." And then I'm like, all right. And then that kind of feel where now healthcare is very seamless, and my whole point is it's more proactive medicine instead of reactive.
So we're going to be launching a thing called Merlin. Merlin is an open source Stanford project. It's not commercially available as a research. By the way, we have IRB and everything. And that in itself takes your scans and literally gives you the number of years you're left with. And it takes a CT, chest, abdomen, and pelvis. So you are right that it is not just about the physical activity, the obstructive sleep apnea or anything. We are seeing multi-omics in place soon. Love it. Love the answer. Edward, Ed, how would you say, what is your magic wand? Because I haven't asked you that question before. You were not present last week.
Yeah, I first things that come to mind are things related to patient experience and clinician experience. But ideally, the quality of care and instant, because it's part of the topic of what I'm talking about tomorrow, is the globalization of healthcare. Like, no matter where you are, whether you're poor or rich, whether you're in sub-Sahara Africa or downtown Rochester, that you're going to get the same level of quality care. So I think AI is the great equalizer to make that happen. So that's my magic wand, because right now it's very uneven. It's tragic, right? Some people could be healed, but they just don't have access. And I think, AI can really equalize that. So that's what I'd love to see.
So, Dr. Kim, one more. What is the difference between personalization and McDonaldization? And why physicians feel like that AI is going to McDonaldize and not personalize? So, giving you a very important example, there's a book by a surgeon who wrote that, flight status checks, how flights made that. I forget, it was Guande or something. I completely forget. Basically, it decreased the surgical errors by 70% by just using a checklist. And I can tell you, as an ICU physician, just asking three things at the end of the rounds for the multidisciplinary rounds: skin, lines, and drains. And the nurse has to answer that. We were able to decrease UTI rate of 27% to 0%, just removing urinary catheters. And that thing was, at that point in time, every single physician, because I was like sitting on top and I said, it is not just going to be in the neuro ICU, it's going to be in the all ICUs. They were pissed at me. Like pissed. Like, who the hell are you to dictate how I provide care, and you're doing McDonaldization and not standard? So explain to me this difference between standardization, McDonaldization. We see a lot of benefits in standardization. And of course, AI is going to be not just a great equalizer. I just went through it. AI is going to be a great equalizer. But the standardization is it going to be a standardizer or a McDonaldizer?
I think you got to pick your battles. Obviously, that's a great example you just brought up. We adopted enhanced recovery after surgery, which is a pretty big move in our surgical post-op care, and getting patients up earlier, removing the Foley earlier, getting them ambulating, eating, walking around, all these things. And, it has shown incredible response. Now, like you said, we've had a few that are saying that this is kind of different than my practice used to be. They're a little bit worried, they're a little nervous about it. But the whole idea is academics, physicians, we rely on best practice for healthcare. And as medicine changes, or you find new evidence and you practice evidence-based, healthcare. So the whole idea is, if you can find that this is truly beneficial for patients, clinicians, and not just anecdotally, but you can really show that, hey, this actually works great for everyone else, and it works best for our patients, it has great satisfaction for patients and clinicians, then I think we should adopt it, And I think AI, the ones that remain will be the ones that really do produce great evidence, produce great results, as well as it's able to be a little bit more moldable than, like you said, the great equalizer.
Beautifully put. You have to pick your battles. And that's really, there are 6 battles that you had to put. And I just told them, everyone, like, just do this for me. I please you. And then eventually, when they show the results, that was like, oh my God. And then everyone was on board, right? Like, hey, within 1 month, there was like, but which is very nice to see these small wins. But I'm just going to be honest with you, in healthcare, it's not this easy and fast to show a result, which is the biggest problem for behavioral change. When you says that, which is from my question is, Ed, actually, you sit in boards and everything. How often do you see actual evidence presented for your decision making? And then, more importantly, same Harvey, when you go to these, social. And then, lastly, Dr. Kim, evidence generation, not at the level of guidelines. Guidelines are going to come, but there's some local realities that we have to be worried about, right? For example, I am from Pakistan, India, and I am more susceptible. So my population in Dallas is going to be different. There's so many things that a local evidence generation needs to be done. So I'm going to start with Ed. Ed, do you actually see, when you're sitting in a board meeting, somebody presenting evidence, or just some loudmouth like me?
No, I think over the years, it's become more evidence-based arguments for sure. However, we all know how to work the game. You can use any sort of stat to make claim. So a topic for another day. But one thing we instituted was the only evidence accepted came through our official data capabilities as an organization. So you couldn't just make up your own stuff like you might have in the past, because that's what people would do. Well-intentioned people, nothing nefarious going on, but you just didn't know if you could trust the data. So we had created a watermark, and only watermarked data, because we knew that came through our trusted source. So yes, the answer is long-winded, but the short answer is yes, it's more and more evidence-based data approach decision-making. But the secondary thing is you have to ask yourself, where did that data come from?
Oh, you're on mute.
Harvey, when you are talking to more ministries and, when you're in discussions with, these kind of higher level plays, is there like rules of engagement set, like Ed said, that, hey, you have to use my data or no data or our data, our institution data, or this has not been formalized, or because at the end of the day, you're talking about at the level of policy making, and not to mention he's going to be putting AI in space with phantom space. So now the question is that when I update a policy, how are you going to do that? So I'm just saying, what are your experience been in that regard?
Yeah, since you mentioned the Ministry of Health for Singapore, when I'm with them, it's very interesting in that it's very central in the sense like, here's Singapore, here are the studies, here's the evidence, this is what we have, and it's pushed from top down. And that has a lot of weight because it can be said to the entire country, this is what the vision is, this is what we're going to do. And so when they're passing the laws, and I'm literally with the Ministry of Health with regulation portion as well, they're like, no, these are the laws, and then this is what's going to happen. And so there's pros and minus on that. But for me, there's a lot of FOMO because I'm like, man, they have this widget, they can pull it off, and lobbyists in the United States are going to fight this one, and we can't have this widget. And anyway, so that's a side thing. But I do want to say the following real quick because I know we only have 7 minutes. Number one, that question about the wand, if you can, everybody put it in the comments. We're going to read those comments, and I'd love to see what you guys think your magic wand, what would be awesome. Second, please share this because the only way of continue to have these is other people knowing about it. So please make sure you share this. But anyway, that's that. And then next.
Dr. Kim, last question. Evidence generation through AI for use case scenario policies and decision making from a governance point, and evidence generation real life for clinical guideline improvement. Thoughts?
I think clinical will always be tougher because that's going to obviously require a lot of review. But I mean, part of my role is to create or I guess generate and retrieve data for evidence for our operational needs. Any small, like you said, the local operational changes that require, our leaders come to me and say, hey, I would like to know how this is going. And I would like to know, to get a baseline idea of where we are. And then we trial some sort of methodology. And then 6 months later, we look at it again. One of the examples we have is we were looking at acute kidney injury coming out of the cath lab. And we wanted to make some sort of change, and our cath lab leaders said, we would like to increase the fluid rates overall. Let's get a baseline of our AKI coming out of the cath lab. Let's get a baseline creatinine. Let's get a base of everyone. Let's get a baseline of how much fluids the patient were receiving. So part of my role is to retrieve that data and make sure that everybody's on board, and we showcase it on our conference and say, this is what it is now. We are going to do this, and we'll see how we are 6 months down the road. So that way, when you give the data, everybody is on the same page.
On that note, thank you, Dr. Kim. Extremely grateful. Thank you for sharing your experience, your advice to our viewers. We're going to bring you back in 2 to 3 months, just find out some updates. We'll get all the guests together, and therefore we can go ahead and then do this. I think, again, thank you for my besties. I'm very excited to see them very soon in person. And I truly think that we are, again, repeating what Dr. Kim said, very start. We have not even scratched the surface. I mean, the user experience in itself is going to changing on my company on a daily basis, because I never used to do agentic AI. Now I can put 6 LLMs in chain or parallel or sequential or one after the other. The amount of intelligence cost is becoming lower and lower. And that's why I made the prediction that overall, the democratization of intelligence was okay, great, everyone would love it. But demonetization of it is greatly scary to me. Thank you so much. See you guys next week.
Thank you, guys.
Just leave, Dr. Kim, leave it